Donc, ce que je vais faire, c'est juste peut-être revenir sur l'annonce, mettre un petit peu de contexte auparavant, mais puisque je travaille à Carleton et que toutes mes notes que j'ai préparées sont en anglais, je vais faire la présentation en anglais de mon côté. So just a bit of context before commenting the bill that was submitted last week. So just let's remember that since the 1960s, all studies that has been looking, analyzing drug coverage in Canada has been saying we need to have universal public pharmacare. It is more efficient. That's the way to go. That better contains costs. It provides better access. And the thing is, Canada never went that direction. We still remain the only OECD country with a Medicare system that does not include prescription drugs, as if prescription drugs were not an essential healthcare service. We still organize drug coverage in Canada as a privilege between employers, offered by employers to employees. And in order to have drug coverage, we also massively subsidize this by not taxing drug benefits. Basically, so the problem with that is, I mean, in Ontario, if you're paid $150,000, basically the subsidy you'll get based on your marginal income tax rate will be like 45% of your cost for prescription drugs, because you're not being taxed as an income for this drug benefits, versus somebody who has only $30,000 a year, basically receive only a subsidy of 15%. So basically, the richer you are, the more subsidized you are. So for some people, the current system works super well. But at the same time, it's just we do have this hybrid system where most people under 65 are covered by the employers, and you do have public drug plans for low-income people, people on social assistance, for seniors as well. So we end up with something like 100 different public drug plans right now in Canada, and more than 100,000 private drug plans as well. Each of them not covering the same thing, not the same type of co-pays, not the same type of deductibles, et cetera, that makes things very, very complicated. And it's not all aligned in terms of maximizing health outcomes for Canadians. It's just when you negotiate private drug benefits, the purpose is to make employees happy, not maximize health outcomes. So we end up with a system that is super costly in Canada. So when we compare ourselves with other countries, we're second in terms of the most expensive system per capita. And at the same time, one of the worst systems in terms of access, what we call cost-related non-adherence, basically not filling prescriptions for financial reasons. We're still doing very poorly. So we're more or less at 10% in Canada. Now, since the Trudeau government is in place, so we had the Standing Committee on Health, 2 years of analysis of Pharmacare, arriving with recommendations. We need universal Pharmacare once again. Then we had the Hoskins reports, so the Advisory Council for the Implementation of National Pharmacare, basically just preparing just a way to roll out prudently the system in a way that will be a win-win for everybody. I wasn't in disagreement with this in the sense it was a bit slow in terms of implementation. It was a 5 years implementation. We start with a basket of essential medicines, and then we start negotiating confidential rebates for all other medicines, and we grow the baskets over 5 years to end up with comprehensive coverage 5 years later. So that was the recommendations in 2019. There was a commitment from the Liberal government to go forward with these recommendations. But then COVID-19, it seems that we ended up in a situation where Canadian government, in a very dire situation in terms of vaccine procurement for different reasons, the United States refusing to export vaccines before they vaccinate everybody on their side of the border. we don't have the capacity to produce. So basically, we started doing the game of vaccine nationalism, basically groveling in front of drug companies to get better access to vaccine doses. And we stopped all the reforms that were in the pipeline that were against the commercial interests of drug companies, be it in terms of pricing for patented products, but also all the stuff about drug coverage that was where there was a commitment. And we had to wait until 2022, this agreement between the NDP and the Liberals, basically the NDP somewhat forcing the Liberals to follow their own commitment when it comes to the Hoskins report. Now, I just want to say, since the Hoskins report, we had a lot of, I mean, the new system would be saving a lot of money. So we're talking more or less of 5 billions on 40 billions we're spending on drugs, at least. Every dollar you save is a dollar somebody else is losing. And let's just say that the somebody that is losing will do everything they can to make sure it doesn't happen. So we've been hearing a lot of falsehoods, basically, a lot of stuff that makes absolutely no sense. Oh, it's going to be costing so much. It's just every household will be saving money on prescription drugs. When you want to reduce taxes, basically, the purpose of that is to increase disposable income for households. And this is exactly what will be happening. Oh, everybody will lose their coverage because public coverage is not as generous. This is complete crap. Can I say crap? I'm sorry. Yeah. The Hoskins report basically made it very clear. It's just employers can still provide supplemental coverage, basically. Provinces can provide supplemental coverage. Everybody can adapt their own coverage to make sure that their employees or population for a province will be well covered. At the same time, it will be saving, it will make employers saving money on drug benefits. So opening capacity for them maybe to cover other stuff. So nobody will lose coverage and every household will be saving money. Now, I just want to say, the question is not status quo versus going with the universal pharmacare. It's just change will be happening. Right now, in terms of rising costs, this is unsustainable. So reforms are coming. The question is which type of reform? And I just want to mention what we've been hearing from private insurers, from drug companies, from Canadian Institute of Actuaries, for example, with Conference Board. This whole narrative that makes complete nonsense in terms of the way we should be reforming drug coverage. So, for example, it's just, let's go a little bit like Quebec. Let's have mandatory private coverage for everybody who can have private coverage. Let's make sure, so that's a bit problematic, but okay, we would have drug coverage for everybody based on a mandatory private system that will be, yes, very profitable for private insurers. Second thing, oh, well, public plans are getting confidential rebates. We should be getting the same rebates for private plans as well. Yes, but private plans, the thing is, they want to make sure that even if the public plans say no to specific drugs, they want to be able to continue to cover it. But the thing is, try to negotiate a 60% confidential rebate on the price of your drug if half of your market says, you know what, if you don't give the rebate, we will still cover for this. So basically, you're shooting yourself in the foot. You're losing all your bargaining capacity. If you want to negotiate confidential rebates, if you want to better contain costs, basically, you need to have the capacity to say no when it is a crappy drug that do not bring any additional therapeutic advance. It's just, I'm not paying 10 times more than already existing drugs. So if you don't have your capacity to say no, that's a problem. And last thing, and the most important thing, a lot of the push from private insurers has been, well, yes, we need Pharmacare, we need universal Pharmacare in Canada, but for the super expensive drugs. So basically, an insurance system, it's about pooling risks. The expensive drugs, these are the bad risks. So let's have a mandatory private entrance system, but let's exclude from that the bad risks. This will be taken care of by the public system. But the thing is, then you have a mandatory private coverage that is not providing an entrance of risk for anybody. This is complete nonsense. This goes against the logic of entrance. Entrance it's about pooling risk. Okay. So finally, we had this announcement last week on Thursday. Announcement is historic in the sense that it's a very small step, but it remains an historic one that lays the foundation of universality in drug coverage. A pleasant surprise. It is with first dollar coverage. This is not something you find in the Hoskins report. There was still some co-pays, maximum $100 per year per household in the Hoskins report. Now this is first dollar coverage. For me, this is a very important point. When people go to the pharmacy, not having to exchange money over the counter of the pharmacist is something that changes your relationship with pharmacists as healthcare professionals. Note that the bill mentioned first dollar coverage for drugs against diabetes and devices and drugs for contraception. It's not clear if it would be first dollar coverage if we grow the basket. I just want to say that the wording is not absolutely clear on this. So two elements are being covered. Contraception, and I will let Christabelle discuss the whole issue on contraception, on the coverage. Diabetes. Diabetes, I just want to say some word. The choice of diabetes is super interesting. Diabetes is maybe one of the conditions leading to the most cost-related non-adherence. It is costly, it is complicated, especially for people with type 1. Not only you need different drugs, for example, insulin, metformin, you also need medical devices such as syringe, insulin pump, glucometers, strips, etc. By the way, the bill is kind of weird. It's just, it will be covering the drugs for diabetes, but not the medical devices. Basically, it says, in the background document they gave us, it says, separate from Bill 664, the federal government is announcing its intention to establish a fund to support access to diabetes devices and supplies. Further details regarding this fund will be providing following discussion with provinces and territories partners, who will be essential partners to its rollout. So basically, just diabetes, yes, for drugs, same intent for devices, but there's nothing in the bill yet, just a commitment that we will do something about it. When it comes to diabetes, socioeconomic disparities is absolutely a huge problem. I mean, we had studies in 2012, for example, by Gillian Booth. For example, just looking in Ontario, people 64, when you arrive at 65, you get automatically covered by universal pharmacare for seniors in Ontario, not when you're 64. So just looking at the differences in terms of health outcomes for people with diabetes, basically we ended up with a capacity to extrapolate numbers of morbidity, mortality. We're talking about 700 people a year dying of diabetes because of not for financial reasons, because of lack of coverage. And that wasn't, I mean, this is 2 jumbo jets a year just for Ontario. This is huge. And this is not the type of argument that seems to make a dent in terms of political will at the time. It still took a very long time for things to proceed. It's a first step. I am pleasantly surprised to see that the old framing of the bill is done in ways to allow growing the basket. It's just, yes, it's contraception, diabetes, but it's instead of a basket of essential medicine, it's a smaller basket, and we will be growing that basket, basically. That's the intent of the bill. Thing is, yes, we created the Canadian Drug Agency as well. We asked the Canadian Drug Agency to organize a national formulary, organize a strategy for appropriate use of medicine, which is something super important because we think about a drug plan just in terms of reimbursing bill. No, it's not just that. You need to make sure you get value for money. You need to make sure that you have appropriate use of medicine. And a drug plan can be a fantastic tool for doing this. But if you don't build up that tool, if you don't get access to the necessary data for this, basically you just end up with a system of reimbursing bill and not monitoring at all what is happening in terms of prescribing habits. Let's just say that sometimes prescribing habits can go adrift, basically, against best clinical evidence and mostly based on the marketing arguments in promotional campaigns by drug companies. Okay. So it is a first step. The bill insists on the development of a national formulary and the development of an appropriate use strategy, absolutely necessary institutional tools. If we want to have a drug coverage that is more rational, more efficient, more safe, and that do provide value for money. While the bill requires for the Canadian Drug Agency to do its homework and submit reports, there is no guarantee whatsoever that the reports and recommendations will be followed or that the baskets of covered drugs will expand. If the political will disappears, there's no guarantee that the basket will grow. However, the logic remains, okay, this is a kind of proof of concept approach. Let's try this, see how it goes. And if it goes well, basically, that will provide us more arguments to grow the basket. I would have personally preferred to begin with a basket of essential medicines, but I can live with a smaller basket at the moment if it allows moving forward. However, can we derail the system? Let's remind that, you know, when the Liberals were in power in Ontario in 2018, they did arrive with a universal Pharmacare for everybody under 25. So the idea was budget can only allow to cover this group of people. Let's start with this, and we ask the federal support to grow universal Pharmacare to everybody. As soon as the Conservatives arrived in power, what they did basically is just, okay, let's remove, not remove that. Let's make private plans first payers. Basically, just take away all the institutional tools we could have put to organize the system in a more efficient and cost-effective way. We will be saving some bucks from the public budget, but we will not be developing any tools basically to make the system more efficient. Is this possible for this one? We do have the Canadian Drug Agency. I think both contraception and diabetes in itself will become very strong arguments to go forward and bring in new drugs versus derailing the system. With C-64, the story is likely to be different because the creation of you mentioned that, because of the framing of the bill focused on developing institutional tools. The whole bill is based on that. We need these tools, basically. Because of the emphasis of long-term funding commitment with the provinces, Patrick will be discussing that anyway. I think such derailing is less likely, but certainly not impossible. A hostile government could stop the growth of the basket of covered medicine, but it will be very politically difficult to just roll back this system. Now, there's the whole issue of the agreement with provinces. Patrick will be covering that. In a nutshell, I'm very disappointed about this bill. I was hoping for way more. I was hoping, in fact, a comprehensive list of medicines to be covered, or at least minimally the OSCON's recommendations for a basket of essential medicines. So it's going too slow, too small of a step, but I have been working on this issue for 15 years now, and it is the first time that something is finally happening. First time we do have a step that is being made, and yes, it is being made in the right direction. So it is a small step, but it is a good step that can really help us go where we want to go in terms of comprehensive universal Pharmacare. Thank you.
So having studied the history of contraception in Canada, I'm going to make some comments about the contraceptive medications and devices portion of Bill C-64. In October 2019, an editorial in the prestigious medical journal, The Lancet, named and shamed Canada as the only country in the world with public health care and no universal public system for providing prescription drugs, explaining that a medley of drug plans, and Marc-André has already spoken to these, they're federal, provincial, private, and employer-based. So this medley, this confusing medley, had led to, according to the Lancet, 1 in 5 Canadians paying out of pocket for medicines that amounted to 30 billion Canadian dollars for 600 million prescriptions in 2016, 4 times what it was 20 years ago. So by providing this kind of contraceptive coverage, Canada now falls in line with other countries with universal healthcare systems that already provide full or partial coverage for contraceptives. So I'm very pleased about this particular coverage and would like to congratulate the Liberal government and the New Democratic Party for their cooperation in bringing about this initiative. British Columbia, which has led the way in the provision of contraceptive coverage, and NGOs, doctors, and researchers lobbying for the necessity of such coverage. What I understand at this point is that Bill C-64 coverage extends to the following prescription contraceptives. So keep that in mind. It's prescription contraceptives: 49 brands of oral contraceptives, 13 brands of copper IUDs, 2 brands of hormonal IUDs, 1 brand of contraceptive injection, 1 brand of hormonal implant, 1 brand of vaginal ring, and 3 brands of emergency contraception. So arguments for the inclusion of contraception in such a bill are cost and equity based. In its policy brief on Pharmacare, NGO Action Canada for Sexual Health and Reproductive Rights pointed out, roughly 47% of pregnancies in the country are unintended, costing Canadian health systems millions of dollars annually. And studies have shown that providing universal contraception coverage could see that entire amount saved in as little as 6 to 12 months. The Canadian Pediatric Society agrees that the cost of contraceptives is the single most important barrier to access, and that youths constitute the population most disproportionately affected by this barrier, with those dependent on parental insurance plans facing additional cost barriers if they wish to maintain confidentiality by paying for contraceptives out of pocket. So overall, states Action Canada, and I'm quoting here, equitable access to contraception is a human right, and it is also a key to realizing public health goals, reducing healthcare costs, reducing health disparities, and achieving gender equality. International human rights law also guarantees all people the right to the highest attainable standard of physical and mental health, which includes sexual and reproductive health. Now, I know from the lectures that I give about contraceptive history is that many of us grow up thinking that decisions whether to use contraceptives or certain kinds of contraceptives are highly personal matters that belong solely to the realm of our intimate lives. And yet, such decisions are made within larger political contexts that are founded in serious social inequities that prove costly to individuals, families, and societies in general. There's plenty of historical evidence to show that men and women have always tried to prevent unintended pregnancies using ointments and herbal potions and spiritual practices in addition to homemade barrier methods. And I can tell you something about those if you want to ask me after this presentation. Condoms have been traced back to the late 1500s, but it was not until the late 1800s with the development of rubber manufacturing, and in the 1920s, the use of latex that made condoms an effective male-dependent contraceptive. Female-dependent contraceptives included the diaphragm and the cervical cap, And these two were mass-produced along with spermicide jellies. Moved by fears over immigration and the presumed threat of the decline of the white race, the federal government criminalized not only abortion, but also the sale, advertisement, and dissemination of information about contraceptives and abortifacients in 1892. Nevertheless, a brisk trade in contraceptives and abortifacients of varying efficacy materialized, even when they tended to be stigmatized because of their association with prostitution, illegality, criminality, and sexually transmitted illnesses. In the 1920s, influenced by the American feminist Margaret Sanger, who was the one to actually coin the term birth control, and Marie Stopes, a British birth control activist, a small birth control movement emerged in Canada, making contraceptives a respectable option for married women who wish to space the births of their children to manage their own health and their family finances. Abortion, traditionally used as a solution to an unintended pregnancy after birth control efforts failed, was driven underground. Very few physicians were willing to perform abortions openly, although the law was interpreted as providing criminal exemptions for abortion to save the life of a pregnant woman. Birth control activists in Canada, the US, and Britain also anchored the appeal of contraception in the rhetoric of eugenics. Only mentally, physically, and morally fit parents should make healthy babies for the nation. A few birth control clinics sprung up to help married women learn how to space the births of their children by using devices like cervical caps and diaphragms, and also spermicide jellies. In 1928 and 1933, spurred on by the eugenics movement, Alberta and British Columbia, respectively, passed forced sterilization laws that ended up targeting poor, disabled, Indigenous, and immigrant individuals. And even today, in 2024, not a lot of students know this fact. In 1936, this directly implicates Ottawa. In 1936, a nurse distributing information about birth control in a poor working class French-Canadian Catholic suburb of Ottawa, known as Eastview, now known as Vanier, was arrested, tried, and acquitted thanks to a loophole in the law that permitted the dissemination of birth control information if conducted in the public good. The nurse's employer, a Kitchener, Ontario industrialist and distributor of contraceptive devices, had been keen to ensure that working men were not overburdened by their large families, fearing that they would be too poor to manage them, and alarmed over the possibility that workers might foment a communist-inspired revolution that he was seeing in different parts of the world. So in the 1950s, Margaret Sanger's quest to find an effective, easy-to-take universal contraceptive for women resulted in the development of the birth control pill in 1953. And the pill, which is a reversible oral contraceptive, is a concoction of hormones, progesterone, and estrogen, and works by suppressing ovulation. The arrival of the pill on the contraceptive scene led to the subsequent development of reversible hormonal contraceptives and other forms, such as contraceptive implants and injections. In comparison to other contraceptives available at the time, the pill was considered very effective. But as birth control was still technically illegal, the pill was initially marketed as a menstrual regulation drug with anti-conception side effects. And after the American Food and Drug Administration approved of the pill for use as a prescription contraceptive in 1960, Canada's Health Protection Branch did the same a year later. So the pill in Canada and in the United States is over 60 years old. As in earlier decades, the pill was upheld as a respectable option for married women. Doctors were cautioned against prescribing the pill to single women out of concern that it would unleash a wave of sexual immorality upon the nation. If you do any archival research, it's really interesting to read some of the fears that were extant at the time. Now, this time, the appeal of the pill was not anchored in the rhetoric of eugenics, which had been discredited by the horrors of Nazi Germany, but in Cold War anxieties over population growth in Asia and Africa. Many in Western countries speculated that a population explosion in poor countries recently liberated from their colonial past would lead them to embrace communism, resulting in a war against the West for its resources. Therefore, the pill was celebrated as a means of preventing geopolitical disaster and even nuclear war. The pill pushed many to see Canada's birth control laws as archaic and backward, and far from reflecting the modern nation Canada was intended to be. Many began demanding legal reforms, including the liberalization of abortion laws, something that was fiercely resisted in many quarters, including among doctors and churches. Reminiscing about growing up in Canada, when birth control information was illegal, the journalist and author Michelle Landsberg wrote, I'm quoting here, "As a young woman, my budding sexuality was shadowed with secretive shame, anxiety, and even panic. It came down to this: male politicians and church leaders controlled, through their criminal laws, my body, my personal life, my most intimate decisions," unquote. No wonder that the consequences of an unwanted pregnancy were acknowledged to be severe, and concerns grew especially for young white middle-class women facing stigma, an interruption or cessation of educational pathways, a derailing of employment and career prospects, and the health risks of an illegal abortion. In 1969, the federal government, led by Liberal Party Prime Minister Pierre Trudeau, passed an omnibus bill intended to modernize the criminal code. The most significant reforms pertain to the decriminalization of contraception, the legalization of abortion, and the legalization of same-sex sexual acts between consenting adults. However, even after the decriminalization of contraception, prescription contraceptives, including the pill, were not permitted to be advertised, and single women still had difficulty accessing pill prescriptions. Why? Well, some doctors refused to write up prescriptions because they confused the pill with abortifacients, and others were morally against sexual relations before marriage. Abortion, legalized under very restrictive circumstances, and again, I can go into that a bit later, proved to be inaccessible to many women. Over the next 2 decades, feminist groups and organizations developed a women's health movement, fought for abortion law repeal, raised awareness of contraceptive safety, including the safety of oral contraceptives, spoke out against sexual and reproductive abuses, against racialized populations, and called for sex education for youths that included accurate information about contraception and abortion. Interestingly, by the mid-1980s, the pill had become the most popular contraceptive among single women between ages 15 to 34. But it remains the subject of controversy for several reasons, in addition to its association with population control. So here's why this prescriptive contraceptive is controversial, remains controversial. First of all, its test history. You may not know that the pill was first tested on animals, a few patients in asylums, some of whom were men, and Puerto Rican and Haitian women who were not told they were swallowing an experimental drug. Another reason, the deaths, strokes, and negative side effects attributed to early high-dose versions of the pill. Furthermore, the pill's promise as a universal contraceptive for all women proved to be false, because some women are unable to tolerate hormonally based contraceptives. And last, the pill's significant role in cementing contraception as a woman's right, but also her near total responsibility for unintended pregnancy, because of the rise of other kinds of reversible hormonally based female-dependent contraceptive options and the ongoing lack of a reversible male-dependent contraceptive apart from the condom, which, as I said, dates back to the 1500s. Other prescription contraceptives, like the IUD and hormonal implants, have also come under scrutiny for the harms they have caused women, and particularly underprivileged and racialized women. So what does this turbulent, approximately 130-year history of contraception mean for Bill C-64? Well, it means that it requires some caveats. So first, by providing coverage for prescription contraceptives only, it is important that access to prescription contraceptives does not become onerous, given national doctor shortages and long wait times to see a doctor, especially in remote communities. The fact that registered nurses in Ontario, as an example, will soon be able to prescribe birth control after taking certification courses and training may help to alleviate this issue. Next, I would like to see Pharmacare coverage extended to all contraceptives. And Marc-André already spoke about wanting a larger basket. So extended to all contraceptives, including non-hormonal and over-the-counter versions, to expand the range of contraceptive choices, especially for those who cannot tolerate hormonally based versions. As well, it's important to note that hormonally based contraceptives do not offer, at least at this point, they don't offer safeguards against sexually transmitted illnesses, but condoms do. Third, governments and regulatory bodies need to ensure that patients are protected in the event that doctors and pharmacists refuse to prescribe or to dispense contraceptives or emergency contraception on the grounds of conscientious objection, and there have been a few cases in this regard. Fourth, contraception coverage in the case of long-acting hormonal contraceptives must not be deployed coercively against underprivileged and racialized populations as a form of reversible sterilization. This is a really ugly history in Canada and elsewhere. Finally, it's vitally important to understand that contraception is just one piece of what's known as a reproductive justice framework. Attributed to Black and Latina women, this framework requires, and again I'm quoting, that every individual be able to make their own choices about their reproductive life and have access to reproductive health services. Reproductive justice also requires that all people have the ability to raise children in safe and healthy environments. It encompasses not only reproductive rights, but also the social, economic, and political conditions that impact whether and how individuals are able to parent with dignity, unquote. Personally, I would like to see Canada working to close the glaring gaps in terms of comprehensive sex education and abortion services, but also in regard to employment equity, housing, environmental protections, domestic violence services, and gender and racial equity. I hope that Bill C-64 ushers in an era, not just of increased pharmacare coverage, but one in which reproductive justice becomes commonplace in Canada, signaling to the world, and in particular to our southern neighbor, which is now grappling with the very serious consequences of the striking down of the Supreme Court decision Roe v. Wade, that equity in sexual health and reproduction is essential to the optimal functioning of individuals, families, and societies. Thank you very much.
Okay, so thank you very much. So I want to thank Vanessa for the kind introduction. I want to thank my fellow panelists for setting the scene. So I'm going to go through this relatively quickly. My remit is to talk about the politics of the announcement of last week. So I'll do that in two parts. Most of what I'll talk about is the federalism dimension. And towards the end, I'll talk a little bit about the politics here in Ottawa. So let me start by painting a picture for you. So it's 1985, 86, somewhere in there. Pursuant to the Canada Health Act, the government of Canada has banned extra billing by physicians, which was a practice where you would go to the doctor, you would be covered under the Medicare package of your province, but the doctor would say, oh, by the way, could you please pay an extra fee of X or Y dollars? And the federal government banned that under the terms of the Canada Health Act. So the province of Ontario then amended its regulations. And as it happened, I had probably the best office I will ever have in my life. I had an office, I was working for the Speaker of the Legislative Assembly of Ontario. I had an office looking south down University Avenue. Those of you know Toronto, University Avenue, this broad avenue that goes from the legislature south almost to the river. On either side, there are a zillion hospitals. And the boulevard, the whole avenue is full of people in lab coats. They had mobilized doctors and nurses and others in these hospitals to be opposed. But the moral of the story is that the Peterson government of the day held firm, did not accede to the pressure. And the moral of the story is there are times in healthcare and in other policy areas where being able to say the feds made me do it is actually good politics. And so that while extra billing is banned everywhere and everybody just accepts that's just the way it is, it took a fight, but it was a fight in which if you were a provincial government, particularly a liberal or conservative government, you could blame the feds. And we may see that a little bit of that in a minute, which I'll try to explain. So let me divide provinces for the purposes of figuring out the Pharmacare announcement. Let me divide them into two categories. The first category we'll call the sort of neutral to friendly category. And in that category, I put BC, and I'd put a basket of small provinces, particularly in Atlantic Canada. So BC, as was alluded to, has led the way to some extent on Pharmacare. There's been a long-standing Pharmacare program, albeit with limits, in British Columbia. This year, they announced coverage for contraceptives, as did Manitoba. So British Columbia, generally speaking, will like both the form and the substance of the Pharmacare announcement of last week. Small provinces will like it because, again, all things being equal, and they rarely are, it could mean dollar for dollar reductions of their budgets for Pharmacare-like programs. So if you're a small province and you cover pharmaceutical products for seniors, under this new arrangement, that cost will be shifted to the government of Canada. So generally speaking, if you're a small province, you probably like this. Whether you make a big deal out of the fact that you like it is a different matter. The second category is big provinces and or provinces who don't like it for program or ideological reasons. So we saw last week very quickly, in fact, Alberta got out even before the announcement saying, we don't like it. Quebec, not surprising to some, said, we don't like it either. Now, in the Quebec case, it's going to be complicated because even if you know nothing about Pharmacare, if you know anything about federal-provincial relations, you can almost count on Quebec to make an argument for an asymmetrical outcome with some justification. In this particular case, it gets more complicated because, as other provinces will, Quebec will claim, strictly speaking correctly, well, we already have Pharmacare. We don't need a federal Pharmacare program. But now we get into which one is better. And we will get continued opposition by Alberta, and perhaps we'll see some of the other conservative premiers. But for the first group, the nice thing about national Pharmacare is, well, even for all groups, but for all provinces, is the design, which was very deliberate, first dollar coverage, combined with a national formulary, combined with best prescribing practices, puts downward pressure on prescribing and on costs. And so if you're a province and your prescription drug bill keeps on mounting because they keep on inventing these new drugs that are incredibly expensive and more or less effective, if you have a national formulary, then you can use that to say, well, no, actually, in our province, we're not going to cover that drug. If you have best prescribing practices, you began, if you're a province and you've been trying to convince physicians to change their prescribing behavior, you have potentially a tool. How much they use it, how strong it is, remains to be seen. So in that sense, we could, but are not guaranteed of getting, well, the feds maybe. Let me turn now briefly to the internal politics in Ottawa. The Bloc Québécois will like this because, of course, they will simply take their lead from the Quebec government, which will say, we don't like it because, well, Quebec doesn't get an asymmetric deal. We just want the cash. Thank you very much. And they will make weak arguments about the current Quebec program. What I don't know is whether the federal Conservative Party and some conservative provinces will echo some of the arguments, including some of the falsehoods that Marc-André mentioned a minute ago. It would be reasonable to imagine a scenario in which the government of Ontario, for example, would go to bat for some big insurance companies who don't like it for various reasons. It would be reasonable to expect the government of Quebec to go to bat for some arguments coming from pharma because of the presence of pharmaceutical companies in Quebec. It would be reasonable to imagine some conservative provinces echoing some of the arguments of the insurance companies. Whether and to what extent they do that, of course, we don't know yet. And the big one will be Ontario. And so far, anyway, they've said relatively little, as has M. Poilievre and his caucus. So we'll see over the next 18 to 36 months, in the run up to and after a federal election, we'll see whether the Conservatives, what position they take. They might take a position quite opposed because, well, everything that the Trudeau government does is bad. That's a kind of hard argument to make, given the way they structured the bill and structured the program. Or they could simply say very little. But the big $1 million question, of course, is, well, what happens now? And the way the bill is structured, it is such that the minister may make payments. So there's no obligation on the federal government to make payments to provinces for Pharmacare. So you could imagine, even if the Liberals were to be reelected with a majority or something resembling the status quo, that they slow walk it simply for budgetary reasons. There's enormous pressure to spend elsewhere. There's enormous pressure to limit the federal deficit. So you could imagine it could take a while before even a Liberal government expanded it. Similarly, you could imagine a Conservative government elected, which doesn't cut it, but doesn't grow it either. So that 5-6 years from now, we have more or less what we have announced today. And everything then will turn on the details of the federal provincial agreements. So let me end by asking, well, what would it look like in 20 or 25 years? There is a scenario in which 25 years from now, if you ask, well, what happened on February 29th, 2024, people will say, oh, wasn't that the day that Brian Mulroney died? In other words, we will have forgotten about Pharmacare. And how would that happen? Well, it would be that there's this bill, and for some reason, the feds are paying the cost of my contraception through a federal provincial agreement, which may or may not be visible to me, but that's all we know. That's a possibility, and I don't rule it out. The other possibility is the one that people have been fighting for 30 years, which is that we actually remember February 29th is the day we got national Pharmacare. And the assumption there is that from small acorns, big oak trees grow, and that the announcement of last week grows into something more comprehensive. We will see. And before I give up the stage and we turn things to Q&A, I would be drummed out of the choir by my public health colleagues if I didn't also mention one of the other downside risks of a national Pharmacare program. The moment you fund something, it defines healthcare. So in Canada, by funding doctors and hospitals, by defining Medicare as doctors and hospitals, we are very reliant on doctors and hospitals. National Pharmacare means we become very reliant on doctors and hospitals and pharmaceutical products, which we already are. From a patient or individual perspective, what's not to like about that? Well, the answer is, it's because we're not spending nearly enough time trying to figure out how to stop people from getting sick in the first place. And so that mismatch of where we invest our dollars over the medium to long term is probably not sustainable. But for the time being, then it's a small win, lots of back and forth, lots of posturing as between Ottawa and the provinces, huge pressure on small provinces to probably say yes, if only quietly, and we'll have to see what big provinces do. But that's by no means guaranteed that the program will grow quickly, but at least it sets a good precedent.
Okay, so our first question, are there recommendations regarding best practices for accountability to provinces or doctors for managing coverage to provide the value for money that Marc-André spoke about? So are there any accountability mechanisms that you foresee in this?
I mean, there can be accountability measures. The problem is that that's not part of the bill, basically. It's just that would be the role of the Canadian Drug Agency. It's just if we give the budget to the drug agency with a mandate to maximize therapeutic value gain for every dollar you spend, for example, then you can have some sort of accountability. In the current system, basically, we have the Canadian Drug Agency. Okay, we're just spending for some drugs, and then we're asking the Canadian Drug Agency to let's develop a national formulary without any budget. Let's develop a strategy. Please report to the health minister in the coming years for this. And then the health minister will decide what happens with that. And that's not convincing. So.
Marc-André's scenario is the most likely one. Let me offer a mildly more optimistic one, is that the legislation requires that the drug agency report back with a year with steps towards a national formulary, report back with a year with steps towards a better prescribing or an optimal prescribing strategy. If you're an optimist, you would say things like, well, then that will get translated into the federal government as part of its negotiations with provinces saying, sure, but you must do this, 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 and this. And then again, if you're an optimist, you get provinces saying, well, yeah, okay, we can do that. But again, this goes back to my example about extra billing. It requires provinces to be able to say politically, oh, the feds made me do it, and then do probably what they wanted to do anyway, which is put downward pressure on their drug costs. Whether they do that is an open question. It doesn't happen quickly. It doesn't happen overnight. And it'll take a while for there to be a consensus around what should and should not be in the formulary and what should and should not be best prescribing. And it will certainly take a while before a federal government says, oh, that's a condition of our funding. I mean, we're nowhere near that, but we could go there.
Okay, this question kind of dovetails, I think, Patrick, off of your presentation. So one of the participants is wondering, what can one do to the Alberta UCP government's refusal to accept this preliminary universal pharmacare coverage?
What can you do? Well, the problem is everybody in this room, we all know too much. For Monsieur, Madame, tout le monde, for Ralph Clinton's former premier of Alberta, and he used to use the phrase, can I explain this to Henry and Martha? Can I explain this to regular people? So the first blush is the government of Alberta said, well, we don't like national pharmacare because, well, we have pharmacare here in Alberta. Well, you do, but it's incredibly limited. So if you think you can, as a province, you can get away with saying, well, the feds are proposing something that already exists, then no, there's not a whole bunch you can do. But if you can get past that and say, well, no, actually, you're comparing apples with Volkswagens, and that the thing that the federal government proposes is much cooler because it's first dollar coverage, albeit for a limited number of drugs. Don't know whether that's going to happen. It will depend in part on how the conversation goes and how civil society reacts. It also depends on how aggressive the government of Alberta wants to be. If they make this the center of their war with Ottawa, they'll spend a lot of money trying to shape public opinion. If they don't, there's an odds-on chance. But the other big thing that's important is that in big cities, some of the more simple arguments just don't wash, right? So Alberta is not nearly as monolithic as we think. And so I suspect if you did the public opinion polls, you'd find a lot of support for an expansion of pharmacare, and the government will have to make a tough choice. Optimist, they would just sort of rattle the cage a bit and then just not say very much. And if I were them, I would just drag my feet and there would just never be a bilateral Canada-Alberta agreement. That would be the smartest thing politically. Because that's actually the biggest single problem, is if all of this is dependent on federal provincial agreements, we're not going to get much soon. We'll get stuff, but it will take a while.
Yes. I just would like to add one thing about this. I think what's important as well is, I mentioned diabetes and issues with socioeconomic disparities, on contraception issues as well, is just what we will see. I mean, these two elements, contraception, diabetes, I think are strategically chosen in a way that it will make an important difference in terms of health outcomes, in terms of the daily lives of women, especially with contraception. And I hope, and you can be sure there will be narratives. Oh, the government is bad. It's not covering this, and why you're not covering that, and this more expensive is. So yes, there will be a lot of mud being thrown at everything that will be proposed, basically. I hope that we will hear the voice of obstetrician, gynecologists in terms of, okay, what are the difference they are seeing now with this new system, hearing from endocrinologists, nephrologists, in terms of the impact of diabetes, looking at hospitalizations for diabetes. I think we will have a very significant difference in terms of, and I hope people with this type of voice in order to be able to say, you know, we're seeing an improvement here. We will hear that not only, oh, government is bad because it's not covering this drug that some people think it could be possible, it has a benefit somewhere, which is likely the main narrative we will hear in the.
Do you have anything to add on contraception?
Yeah, I mean, I just think that there will be numerous lobbyists and organizations and feminist groups that will hold their feet to the fire. I think that's inevitable, and it probably will work. Yeah.
Okay. Noting the limited baskets, we've talked about the baskets of coverage for this round. What do the panelists see as the likely next round of coverage? I know there's been some skepticism about how fast this might grow or whether it might grow at all, but if it grows, what do we think the next steps might be?
A literal reading of the bill might suggest that because the drug agency is supposed to, with rural sense, they have a month and we're supposed to kickstart the process of getting a national formulary. So from a purely rational point of view, if a bunch of smart people go out and come up with a national formulary, then the formulary gives you the menu from which you would choose. How you choose particular classes of drugs within a national formulary, not sure. But I suspect, as Marc-André alluded to, it depends what your objective is. Is your objective to deal with issues of socioeconomic disparities? Well, then certain drugs are more interesting than others. Is your interest to be politically popular with the most people? It's hard to say. But one thing is for sure is that reasonable people can disagree on what should be next, and provincial and federal and the federal government will be negotiating that. And so some of that will depend on how much pressure provincial governments put. The worst case scenario is that Big Pharma, while the rest of us are playing checkers, Big Pharma plays three-dimensional chess. So the worst case scenario is that we end up with, in the next round, making choices based on that, which makes the most money for pharmaceutical companies or drugstore chains. That is within the realm of the possible.
I would like to add, I mean, rationally, everything is organized in order to grow this basket. For me, what would be the rational next step would be the first step of the Hoskins report, basically the basket of essential medicines. So we're talking about maybe 120 drugs that is covering more or less 66% of the health needs of the population. At the same time, this basket of essential medicines, most of them are generic and they are on the low cost side, basically. So that would be the rational thing to do in order to maximize the impact, the health outcomes, and organize a system on a more grander scale. However, one of the big push right now I was mentioning is just, okay, want to take all the bad risks and just dump them in the public system. The thing is, when it comes for super expensive drugs, a lot of people are pushing is just, this is the only thing that the federal government should be covering, which is kind of weird because at the same time, a lot of the narratives in terms of how much more generous private coverage is because they're covering these super expensive drugs that sometimes government is a bit reluctant or hesitant to reimburse. Thing is, if these super expensive drugs becomes the next step, the thing is, it's a bit of a problem in the sense that you need to develop your institutional tools to deal with these drugs. So especially, so one tool that we can have is what we call outcomes-based risk-sharing agreements. So it's just when this new super expensive drugs for rare disease is coming on the market, we have very little data in terms of what are the benefits of that drug, what are the risks associated to that drug, and at the same time, basically a super high price tag for this. So a risk-sharing agreement saying, you know what, we accept to cover this, but let's in 2 years in terms of the health outcomes, let's look at the data, and if the therapeutic benefits is there and there's little risk associated to this, yes, we'll be paying the full price for this. Otherwise, we need to find a way to maybe not pay the full price, have a reduced price, or take off the drug of the market if the drug is super problematic in terms of safety. But these are tools that are a bit more complex, and that would not be for me the most rational step. At the same time, it's just we need a comprehensive coverage for all cost-effective drugs as soon as possible. We do have a national strategy for rare disease that will be helping in terms of putting some money to have better access to some of the more expensive drugs. But now we need the institutional tools to make sure that we do get value for money as well for these expensive drugs, even for rare disease, in a way that we can collect data, analyze this, monitor what is happening, and reorganize the system accordingly. But this adaptation, it's more for the long term. The next step, the rational one would be, okay, basket of essential medicines that would maximize health outcomes at the moment.
Thank you. I'll just say quickly that because contraception or prescription contraceptives will supposedly be covered, I think it's going to open up the door and perhaps looking at infertility treatments, drugs used in trans medicine, and possibly even medications for managing menopause. So I think this is going to open up a whole lot of directions.
Okay. Again, the early days for this, and I'm not sure if you know the answer, but it's an excellent question. How does national Pharmacare affect Indigenous people's coverage?
That's a very good question. So, from a strictly administrative point of view, some could say, Indigenous people are already very well covered in the sense that the non-insured health benefit system basically is just, okay, you have priority with the private coverage you can have or the coverage you have with the province, and any additional co-payments, deductibles you need to pay is taken care of by the federal government through the NIHP. But the thing is, like I said, it's just we have a lot of different public drug plans, private drug plans. You might have a spousal plan as well. When you become very sick and you need to start navigating the administrative complexity of all this, it is always very, very difficult. And for many Indigenous people, not living in large urban areas, the navigation of this complexity is especially challenging. The whole idea of the national Pharmacare that is being put in place is just, that will be your first line of coverage on which we build institutional tools. So basically, it's just we're not asking you to start doing the calculation with all the different types of coverage you have, you might have, you could ask to your province or something. Basically, no, we're covering this already, and we're doing we're doing this in the most straightforward way to make sure that you don't have cost issue when you need to access your drugs.
The only other thing worth adding is that, of course, only some Indigenous people are covered by federal programs because they're considered they're covered by the Indian Act. And so in a province like Manitoba or Saskatchewan, where 10, 12, 13, 15% of the population is Indigenous, anything that benefits the people of Saskatchewan and Manitoba will benefit Indigenous people disproportionately. So Wab Kinew last week already said positive things about the federal Pharmacare proposal. For Indigenous people generally in Manitoba, that's a good thing. But again, we won't know until we actually get a bilateral agreement as between the government of Canada and Manitoba.
What are the potential implications for data on pharmaceuticals and their use, particularly in terms of data collection by the private sector flowing from this? And I think this also has some interesting dimensions when we think about accessing contraception.
That question could have a whole bunch of assumptions built into it. So let me just start. At first glance, if you empower the Canadian Drug Agency to build a national formulary and to do better prescribing, as part of that, we need to take the data we have and get more data. We need to know way more about what's actually happening, prescribing patterns, and things like that. So there will be, more than likely, more data rather than less. I suppose from a privacy perspective, one could raise concerns. And I'd have to think more about how that might work. But I think the broad rules and norms governing insurance and private insurance, public insurance, and the privacy built in is probably what we're going to rely on. Whether it would make, from a pure privacy perspective, things better or worse, I'm not sure.
No, recently I wanted to do a research project on the marketing of opioids. I asked basically the company that do have access to the prescribing data, which is IQVIA, and basically they were asking me $120,000 to just get the access to the prescribing data and marketing data for opioids in different provinces. So we did not do the project, basically. These data already exist. That's the thing. But they are being organized by private actors for private benefits. So IQVIA has the prescribing profile of every physician's at the individual level. I mean, yes, some provinces do have some rules to avoid the individual level. There's tons of ways to circumvent that. So then these data is being sold back to drug companies that can basically adjust their marketing strategies. You can know very well, okay, when we did this marketing blitz with these doctors, this is the exact impact we had on them. For this specific doctor, this type of approach is not working, this other type of approach is working, and blah, blah. So these data are already out there. The thing is, they are not being used in order to maximize health outcomes for the population. They are being used to maximize sales for drug companies, and that's a huge problem. Now, for the public researchers who wants to look at appropriate use of drugs, for example, the problem is that in most provinces, BC is an exception. Ontario is doing better now with the ICS, the Institute of Clinical Evaluative Sciences. But still, in most provinces, and when you go to see your doctors, most of the time your doctors ask, well, do you have private coverage? Because my prescription will be different if you have private coverage or not. So everything that is with public coverage, normally we do have access to this because the public drug plan do collect the data. But if you have private coverage, basically, then this is the black box. We just don't know what's happening with this. And I was mentioning my research project on the marketing of opioids. I mean, for me, it's not a surprise that Countries like United States and Canada are the two countries stuck with this opioid crisis. I mean, there's opioid problems in other countries, not the same type of crisis of what we have. The fact that we did not have these institutional tools, you know, when a dentist is prescribing 1 month of OxyContin to a kid because of a root canal, that's a problem. And somebody needs to say that something must be done about this. We did not build these institutional tools. We did not do nothing about this. And that's a real problem.
Thank you. When I hear data and contraception in the same sentence, the first thing I think of is confidentiality and privacy. So I'd want to know how technologically, how this data will be managed and safeguarded. And I'd also be curious as to whether it would be subject to something like an access to information request, whether it's coming from a genuine researcher, or it's coming from something that, or someone that might be a bit more questionable.
I would like to add something very quickly on this. I was part of au Québec, la commission d'éthique en sciences et technologies basically had this report looking at issues of confidentiality in order to provide access to administrative health data, so which is not only drugs, but health data in general. Because we had the Ministre de l'Économie, Pierre Fitzgibbon, at the time say, oh, well, we're sitting on a gold mine with all these health data because drug companies would like to use this. So in order to attract investment, we will basically sell away these administrative health data, and we will give basically drug companies priorities over public researchers, which was like complete nonsense. And from there, the Ethics Commission decided, okay, let's maybe write something about this in order to explain what should be done with these data. But discussion with different ethicians for this report, the issues of confidentiality, it's an important issue. But I mean, this is not a big problem. It's just there's a way to deal with this. A lot of other jurisdictions, countries are using these data, have been dealing with these privacy issues. So this is not a barrier, basically, to go forward. But we need to make sure we have some safeguards. Exactly.
Years ago, when I was working for the government of Saskatchewan, I was the executive director of the policy branch, and I had health privacy as part of the files that I dealt with. I'm here to tell you that Canadians, people in Saskatchewan, Canadians generally take the privacy of their health information very seriously, and the people who take it very seriously are very loud. So governments have got the message loud and clear, you mess with my health data at your peril. The good news also is the government of Canada is completely preoccupied by this as well. So one of the answers to the questions or the concerns that were raised, and again, it'll be interesting to see, but I'm pretty confident that in the bilateral agreements, there will be sections on privacy. And the minister's dreams notwithstanding, the general trend is that governments are pretty aggressive in protecting health data. There are ways of getting around it and of de-identifying data, but the government of Canada is, in particular these days, very preoccupied by this for good reason, because if you've ever met a politician who's had to defend the privacy of health information, they have battle scars and they'll tell you the story. And so I think that's to the good, but again, we won't know until we see the detail.